Hi everybody, welcome back to AP Psychology with me, Miss Baines, your teacher, where you are able to pause and rewind me as I deliver you your latest content. So go ahead and grab those flare colored markers, a nice comfy space in which to work, and of course, don't forget those ever important binder notes that go lockstep in order with this video called Unit 8, Video 2, Anxiety, Obsessive Compulsive Disorder, and Related Trauma and Stressor Disorders. On page 3 and 4 in your new Unit 8 Clinical Psychology binder notes. I'll see you on the other side. Welcome to our second set of notes in this unit on mental illness. As you can see from our learning targets, we're going to be talking about a couple of categories of disorders. One being anxiety disorders, and the other two categories being obsessive compulsive and related disorders, and then the third, stress-related disorders. Now they are separate, so there are anxiety disorders, then there are obsessive compulsive and related disorders, and then there's the third, the stress and trauma related disorders. So let's just jump right in and talk about some of the prevalence, because again, we're not just learning about this to do well in our AP exam, right? We're learning about this because we're talking about human beings. According to the Anxiety and Depression Association of America, anxiety disorders are the most common mental illness in the United States. It affects 40 million adults ages 18 and older. That's 18.1% of the population every year. And that's just people who admit it out loud. According to the National Institute on Health, an estimated 31.9% of adolescents between the ages of 13 and 18 have had an anxiety disorder at some point in the year. Now, this is using the DSM-4 criteria, so we have to keep that in mind. The ones that we're going to be talking about, as well as the OCD, obsessive compulsive, and even PTSD and trauma, stress-related disorders, right? There are three very different categories, but all still very prevalent. His name is Tony Dorsett. If you don't know him, he is one of football's greats. He makes no secret about his fear of sleeping in the dark. He has a phobia of sleeping in the dark. He will admit this, right? Even though he's a grown man, he leaves the bathroom light on and the door cracked open in his bedroom when he's sleeping. There's always a ton of lights on in his entire house, and he very much feels a phobia of the dark. Another one being John Madden, right? Another large, giant football guy, right? He used to be the coach of the Oakland Raiders, and now he's a TV sports personality. He suffers from panic attacks when he's on a plane, so now he never ever flies. Even when he wants to travel in luxury, he doesn't fly. Briefly talked about this, but the new categories of disorders that you need to know, that they used to all be under one umbrella called anxiety. But now, at the bottom here in the DSM Volume 5, you need to understand that anxiety is its own category, including these three separate things. Or panic disorder and phobias are all still three very different disorders. Okay, so OCD and related trauma and stress related are separate disorders according to the DSM. We'll talk about why. Some of the general qualities of an anxiety disorder include the feeling of being worried. We really know that a lot of people have a very good understanding of what anxiety is, but it's good to just put some words to it, right? Worry, fear, apprehension, intrusive thoughts, meaning drilling their way into your brain and you can't set them aside. You can't tell yourself to stop thinking about it. You don't want your physical symptoms and feelings of tension to be going on, yet they seem to have an automatic quality to them. So like, I need this uncontrollable reaction. It's not that somebody wants to feel or think or behave in a certain way. It just happens, right? It happens because that's the way feelings work. If we could get rid of our bad feelings, we would. So we have these three things, GAD, PD, or general anxiety disorder or panic disorder, phobia. Okay, so we'll start talking about general anxiety disorder first. This is a prolonged, often vague and unexplained, but intense fear that do not seem to be attached to any particular object. I would write that one down right now and highlight it, because that is really the marked aspect of GAD, of general anxiety disorder. There's really no telling where an anxiety is coming from, right? They just have this underlying, percolating, prolonged feeling of, I don't know why, I don't know where this anxiety is coming from, but I feel really anxious, not at ease, okay? 4.1 and 6% of the population have experienced GAD or GAD, more common among women, and it tends to be in between people's late teenage years and early 20s, right? You feel this overwhelming sense of anxiety all of the time. You don't know where it's coming from or why, and you know that it's not one particular thing that's bothering you, right? It's not that you're afraid or worried about something concrete, right? The symptoms include excessive anxiety, worry occurring for at least 6 months, so persistent worry. This can't be like a seasonal thing in life. It has a specific cause, an inability to control the worry. Once I was down in the Caribbean somewhere, and it was one of these cultures that had a lot of tiny dolls that they made called worry dolls. And if you kept them in a little box under your pillow, they would take all your worries away. I don't know about you, but I'd be willing to try anything, right? When you're feeling that feeling of somebody sitting on your chest and you just can't get the anxiety to subside. You know, cute little dolls, if they work and they make me distracted for even a minute when I'm feeling that anxiety, bring on the worry dolls. Okay, so considerable distress, right? There's one of those D words again, or an impairment in social, occupational, or other important areas of your life, right? Within your relationships. You have the presence of 3 or more of the following: restlessness, easily fatigued, difficulty concentrating, or like your mind suddenly goes blank and you have this moment of like you don't remember something. Okay, so oftentimes people with GAD also have a panic disorder, but they're still separate. So someone will be diagnosed with GAD, meaning a general anxiety disorder, with panic disorder indicators, which are similar to GAD but with panic disorders, except that they are greatly magnified and usually have a sudden onset. It's not just kind of growing over a continuum of days or months. It's an instant where everything comes on quick and you have like actual physiological things going on in your body where you might even think you're having a heart attack. It's so strong. Okay, this is more common among women and younger people. The clinical features of this one being it's recurrent. Okay, it happens more than once. It's unexpected and it's a panic attack. It's an attack, like an attack on the central nervous system. It's a really amped up moment that lasts for several seconds, if not a couple of minutes, and then it persists, coming on and off again over a long period of time, perhaps a month. Some of the symptoms are shortness of breath. You feel like you can't breathe, you can't catch your breath, someone is stopping you from breathing, like sitting on your chest, and then that causes dizziness or kind of unsteadiness. You can't catch your breath, you get feeling faint, you start shaking and sweating, your hands are moving, and you can't talk, you can't speak, right? You might be having a panic attack. Choking, nausea, stomach pains, right? Tingling, chest pains, shooting pain radiating sometimes down your arms, discomfort, a sense of strangeness that you don't know where you are, that you're in an unfamiliar place, right? You feel like you're going crazy, you're losing control, or maybe you're about to die. That's how a panic attack actually feels. So it's really super intense, okay? The intense fear. And the last one under anxiety disorders is what we call a phobia. This is marked by a persistent and irrational fear. So it's really important for you to underline and highlight this. Irrational is the key word here. It doesn't make sense, okay? You're not sure that these things could cause some harm, right? They could cause danger, but your response to them seems not logical. It's not necessary. It's like over the top. It's causing some sort of distress, right? One of those D words. It's an irrational field, an object, or a situation that disrupts behavior. And this chart kind of shows you some of the common ones, okay? Heights is a big one. right? The fear of blood, oftentimes accompanied by just seeing a needle, right? You're conditioned and you start to feel weak and dizzy just seeing the needle because you know blood is going to be coming soon. Sometimes people feel claustrophobic in small spaces, storms, being alone, being locked in an elevator, being around certain insects or bugs or snakes or I don't know. Blow everything out of proportion, reality seems inexplicable, and you lose voluntary control of your emotions. You're afraid. I'm not lying about it, right? I really can't control it. So it's important for you to get these kinds of phobias down. A specific phobia is what you normally think of when you think of phobias, right? The irrational fear of a particular object. So for me, that might be spiders, claustrophobia, being in closed spaces, water, hydrophobia. There's a kind of social phobia that people suffer from, the fear or embarrassment of interacting with others. Public speaking is a huge fear, right? Being in a social environment where you have to be on stage and perform in front of a lot of people, or getting embarrassed by talking out loud in front of your classmates. You need to make sure that you have an understanding of how social phobia is different from something like agoraphobia. Agoraphobia is the fear of fear itself. Make sure you write that one down. The fear of entering certain fear-evoking or unfamiliar situations. So that is why fear, nothing but fear itself, is a quote, right? Where you might be fearful, which often accompanies, you guessed it, a panic attack. So agoraphobia is very much accompanied by the symptoms of panic attacks. This person will avoid crowds where the attacks could possibly occur, and they avoid being around a lot of people or even wanting to go outside into any situation where of this phobia they have may occur. So oftentimes what you find with people with agoraphobia is they never want to leave their home, right? Because they even though they may know that there is, let's say a fear of an elevator or an enclosed place like an elevator, and they're afraid that they're going to have this strike up of fear and panic attack in that elevator. They know that they are going to go somewhere where they will not be able to get on an elevator, right? And if there aren't stairs to get them there, if there aren't stairs available to them, but they still won't leave their home just because there's a small chance that they might not be able to avoid that elevator. So they rationalize it and sort of just stay home for be better safe than sorry, right? They would rather stay home in their house, sometimes in many cases for months, sometimes years, never leaving their home, just to make sure that they avoid that fear, right? That evoking situation. Okay, let's shift away from anxiety disorders into obsessive compulsive and related disorders. Okay, this is OCD, right? One kind of myth busting that we need to do here, I guess, is what word you could say is when somebody says they're so OCD, right? They want everything just so in a certain order. There's a difference between anal retentive personality and tendencies of OCD. There's a difference between anal retentive personality and tendencies of anal retentive personality. Just like there's differences between obsessive compulsive tendencies and personalities, and are very similar but different from obsessive compulsive disorder. Okay, the disorder is what makes it different. Just because someone likes everything tidy and orderly or might wash their hands often doesn't mean that they're necessarily obsessive about it or that they have obsessive compulsive disorder. It's important for you to really pay attention here and see, okay, what's the difference here? Okay, it is the persistence of unwanted, pervading thoughts. I want you to write that down. Intrusive thoughts. These thoughts that when the person does not want their brain to be talking to them, but they get in there anyway, and the obsessive part is, right, the obsession equals the intrusive thoughts that keep recurring. It's a persistence of those thoughts that keep saying, make sure you do this, make sure you do this, make sure you do this, make sure you do this. accompanied by the urge to engage in what is basically a bunch of senseless rituals that will temporarily alleviate the obsession. Okay? These compulsions are rituals, senseless rituals to alleviate the obsession, and that is where the disorder comes into play. There is a neurological connection, and I'm kind of oversimplifying this, but there's a neurological connection. There's a neurological connection in the mind of the OCD patient between the compulsion, which is frankly ridiculous, right? There is no explanation for it, but there is a connection between that compulsion, that ritual, and the obsession. Okay, so let's just say that the intrusive thought is that this mother and son is going to die, right? She's a healthy woman, he's a healthy little boy, he's safe, right? Hey, sure, anyone could die at any given moment, but hers is an obsession. She thinks about it constantly, and it keeps entering her brain around the clock. She has these compulsions where she has to turn the lights off, on, touch this, touch that, turn on the faucet, off the faucet, on the faucet, off the faucet. She believes if she does these sets of rituals in a certain order, that it will keep her and her son alive, right? It will stop him from dying. That's the irrational part of it, right? There is no connection between turning the faucets on and off, or turning the lights on and off, or repeating phrases, or doing any series of irrational things or rituals that are going to make it so that you have a better chance of somebody not dying, right? It doesn't work that way. So you have to get down the cycle part, okay? The person has an intrusive thought, and then they have this intense anxiety and stress over it. So they do this compulsive ritual because maybe it will help give them a sense of relief for just a little short period of time. Then the obsession comes back, and it's this very ugly, hard to get out of cycle that people with OCD do, not to quote or do anything with certainty, so they just don't trust their own senses. Right? So they do these things, they do these compulsions or these rituals over and over and over again because they don't trust that it's going to be okay. They don't trust their own decision making. Therefore, if they don't trust their own decision making, what part of the brain would a biological psychologist say is affected in the brain of an OCD patient? Decision making, right? The prefrontal cortex, right? The frontal lobe, right? So some brain imaging of PET scans of a brain with a person with OCD, there's a high metabolic activity, meaning that red that you see here on the screen in the frontal lobe areas involved with directing attention. Now we need to make sure that we discuss some OCD-related disorders. I want you to keep in mind here that they are under the obsessive-compulsive disorder and related because they are related, right? So for instance, we kind of explained this body dysmorphia a little bit when we were talking about anorexia nervosa and bulimia, right? It used to be considered what we now call somatoform disorder, right? Soma is of the body. So trichotillomania, as well as for X or eation disorder, is also of the body. But that doesn't make it a somatoform disorder because it involves such noticeable, I guess you could say, compulsions that surround some sort of intrusive thoughts. Okay, so let's talk briefly about body dysmorphic disorder. We're going to talk a little bit more about it in a second. It's this preoccupation with an imagined or exaggerated defect and a personal, again, exaggerated, that somebody might have this large or large-ish or larger nose, or it's exaggerated in their own minds as being much bigger than it actually is. And they can't kind of stop obsessing over it. That intrusive thought keeps coming into the brain, and the essential feature of body dysmorphia disorder is the belief in an imagined defect in your appearance, right? Hoarding disorder, you've probably heard of this before. There's lots of shows on streaming, right, on people hoarding. They have this thought that they have a problem of getting rid of anything, that they're going to regret throwing something away. And it's so bad that it's a disorder, right? It's dysfunctional and somehow deviant. It's messing with their lives. It's a persistent difficulty to part with their own possessions because of the perceived need to save them no matter what the value or lack of the value therein. There's a distress at the thought of getting rid of any of their items, a severe distress. Trichotillomania is pulling out of the hair pulling disorder. It's the recurrent, irresistible urge to twirl and pull out the hair from any part of your body. So not just on top of your head and your scalp, despite trying to stop, you can't, or pulling out the hair on your arms or your legs or whoever knows where else. Excoriation disorder is skin picking, where you repeatedly pick at your own scabs, resulting in lesions and causing a significant disruption in one's life. Okay, it's not just like some kind of tick or habit, right? It's very much disrupting their lives. You're consumed with it, and you're constantly trying to find ways to do those rituals or do that activity that's attached, and this preoccupation, right, of this perceived or imagined or exaggerated defect. Let's say an appearance, okay? It's time consuming, often being about shape or size of either your facial features. Maybe you have some acne or freckles or spots on your skin. Maybe you're starting to wrinkle or your hair is thinning. Individuals with this experience marked distress over their supposed deformity. Okay, lots of distress, feeling totally self-conscious about their defect, right? It might even lead to the avoidance of going to work or out in public in certain situations, right? They have higher rates of major depression disorder, suicidal tendencies. Body dysmorphic disorder typically becomes evident in adolescence, right? When there's more focus on what you look like, right? You don't really care that much when you get into your 30s and your 40s what people think. But when you're a teenager and you're just getting comfortable with your new body, you're always really hyper focused about what people are seeing and what you see in the mirror, right? It's normal to feel that way. But when it becomes intrusive, when it becomes that you're so self-conscious about it that you can't go to work or school, right? Or you're severely depressed and can't get out of bed because of it, there's a problem. There's more to focus on what you look like. And it does also affect males and females equally, which is interesting. Here are some examples of what individuals with PD, quote, see when they look in the mirror, okay? It's not that they see this exact image, right? She doesn't believe that her skin is actually that long, but when she looks in the mirror, it's exaggerated in her own visual field to her. Right? It's all she can look at. It's all she can see. She's totally preoccupied by it. I say that it's a she because of the images here in the slide. Again, it does affect both males and females equally. And again, it's an exaggerated feature. It's not that they actually look like that or that they are that way. They might have a larger than average nose or ears or eyes or whatever, but she might have a big chin or a long chin or a short neck or a fat whatever in their visual field, and they have an exaggerated eyesight. A human, right, the human Barbie, the living Barbie, she's 50 years old, about my age, probably maybe older now, right, a little older. She's from the United Kingdom. She has had over 100 procedures costing over $1 million for various cosmetic enhancements. Recently, she's been in the news for allowing her 16-year-old daughter to begin Botox treatments. Okay, again, this is her at 50 years old after 100 plus procedures and surgeries. This is her when she was a little younger, before she had the procedures. Again, just seeing things that are wrong with you and focusing on them constantly, right? The things that you feel are, quote, wrong with you, that is very exaggerated. And obviously this is causing her some kind of distress if she's willing to spend upwards of $1 million to fix it. Okay, it's very time consuming to be obsessed over what you're seeing in the mirror. She is having an intrusive thought and therefore obsessing over it. Okay, the last category we'll talk about is trauma. The biggest one here is PTSD, post-traumatic stress disorder. Okay, something, and Here's a kind of myth-busting thing about PTSD. We need to do right now that oftentimes the prototype, right, there's a vocab word for you. The prototype you might want to think about is the war soldier, okay? Of course, they go through terrible trauma when they're at combat. Soldiers do. Yes, they experience PTSD at higher rates than almost anyone, but that's not the only people who experience PTSD. Anyone who goes through a major trauma or heightened bout of stress in their life, right, victims of abuse, oftentimes, right, of whether it's a robbery or an assault or sexual abuse or child abuse, anything like that, can experience PTSD and get triggered. It's got to be 4 or more weeks of the following symptoms in order to register as PTSD, okay? Haunting memories and nightmares, flashbacks, and therefore social withdrawal, because there's a lot of these symptoms. And just because they can't get away from these haunting images, they're feeling constant anxiety. They're thinking about it. The haunting memories and the flashbacks are also causing sleep problems. And then there is some resilience to PTSD to kind of keep in mind. Only 10% of women and 20% of men react to traumatic situations and end up developing PTSD. A lot of people are impacted by trauma. You would think that this would be a more prevalent demographic, but Holocaust survivors have shown remarkable resilience against traumatic situations. All major religions in the world suggest surviving a trauma leads to the growth of the individual. And it's not that you want to live your life waiting for trauma to happen so that you can get stronger. Also, we don't have to believe that just because you are a victim or have experienced something that most people would consider traumatic and you're able to deal with it in a healthy way, that you are automatically a disordered person, right? Or that you're handling it wrong, or that you're not digging in deep enough, right? A traumatic instance of itself you shouldn't believe that you're disordered necessarily, because other than PTSD, there's also acute stress disorder. It's very similar to PTSD. However, it starts immediately right after the trauma, whereas PTSD normally has kind of a period in between the trauma event and the disorder. There's a space of time that the behavior and then the acute stress disorder lasts from 3 days to 1 month. So it's a little bit more intense, but it's shorter lived. These two acute stress disorders and PTSD were previously considered anxiety disorders. They're not anymore. Not always do these patients experience anxiety, right? It's that they have the stress. They're responding to the trauma in a certain way, but it doesn't mean that they have anxiety about it. Rather, they may be experiencing stress, although they could still experience anxiety, or maybe they're just angry about it. Maybe they're feeling aggressive or some kind of disassociation or other symptoms, not necessarily that are called anxiety. All right, let's talk about the perspectives. What do they have to say about the learning perspectives, saying or suggesting fear conditioning leads to anxiety? Think of this particularly with phobias. This anxiety that gets associated with other objects or events, like stimulus generalization, is reinforced so that the fear responses are inculcated through the observational learning. The young monkeys develop fear when they watch other monkeys fearing the snakes. Observational learning. In the biological perspective, with GAD, panic attacks, even obsessive compulsive disorders, it's linked with brain circuits, right? Like anterior cingulate cortex, the cingulate cortex, and then they have found a specific spot on the OCD patient at more active in the prefrontal cortex, but that the OCD patient and other patients of anxiety have this specific brain region that is impacted. All right, thanks for tuning in. That's all I have for you for today. I'll see you tomorrow. Bye now.